Thank you for joining us today. I am very excited to have our guest, Dr. Mastin, here. And Dr. Mastin is a double board certified dermatologist joining us from where he practices in Missouri today to talk about skin cancer. And Dr. Mastin, tell us a little bit about yourself and your background.
Okay, thank you so much for having me. I'm originally from a small town in Iowa. I trained at the University of Missouri Columbia for medical school, and then I trained at the Mayo Clinic in Rochester, Minnesota for residency. After that point, I went back to Bolivar, Missouri, which is a small rural hospital setting that I practice in. I also own an aesthetics practice there as well. I deal with everything from children to the elderly, deal with everything from skin rashes to skin cancer, which we'll be talking about today.
That's awesome. Well, thank you so much for joining us. You're a very experienced Mohs surgeon, general dermatologist, cosmetic dermatologist. So, very excited to have you on our show today. So, let's dive right into it. Today, we are going to be talking about your definitive guide to treating skin cancer. So, if you've been diagnosed with skin cancer, or one of your loved ones has been diagnosed with skin cancer, we're going to be breaking down all of the different treatment options for you, from least invasive to most invasive, so you can make the right decision for you or your family member. So let's get to it. So, least invasive skin cancer treatments. If someone's diagnosed with the basal cell or squamous cell, what is the least invasive treatment option?
Yeah, thank you. So topically, we have a couple drugs that I commonly use. One would be a imiquimod, and that works with your immune system. Not everybody has those receptors, but that was kind of the standard for a while. And now more likely you're going to use something called five-fluorouracil or FEDEX, and that's kind of gold standard, I think, for topical therapies when it comes to creams. These are good medications, but ultimately it causes a significant inflammatory reaction. It can be kind of an issue for patients to tolerate sometimes, but it does decrease your risk for developing a skin cancer, but it usually needs to be repeated because we're getting ongoing sun damage in a lot of these cases.
Okay, so this is something that patients will use for a period of time, and there will be a healing process from it for a couple weeks.
Yes.
Okay.
Masting, scaling, erosion, or breakdown of the skin are common things that I hear. Um, Ultimately can be a little bit uncomfortable, but in the long term, I think it's a real benefit. At least for about a year's time, there's about a 75% reduction in skin cancer for like squamous cell skin cancers, which is second most common type of skin cancer.
Okay, so you're treating it with a cream basically that you do at home. There's no surgery or stitches. So,
Correct. Yeah, usually about a 2-week course. Sometimes you can modify the protocol, and I don't think there's really a standardized form of it.
okay, and this is something that they have to go to their dermatologist to get a prescription for, right?
Correct.
Okay. Okay, so see your dermatologist if that's something you're interested in.
Yes, please.
So, what would the next option be?
There are oral medications, and some of these are used off-label, meaning that they haven't been studied by the FDA for these indications. One that I commonly use for people that make multiple skin cancers, primarily squamous cell carcinoma, or they have an increasing rapidity at which they make these skin cancers. That's a medication that is taken daily by mouth. It's called acitretin, and some of the side effects that people commonly deal with are dryness, brittleness of nails, thinning of hair. It needs to be used for about a year's time before a 66% or so reduction in skin cancer, and it needs to be taken long term. But it is an option that you can do. We do have to watch certain laboratory values as well. Newer indications or areas that they're looking into for treatment would be things like capecitabine, which is technically a chemotherapy agent that was used for gastrointestinal tumors.
Okay.
And they use it at a lower dose, but it's actually converted into five-fluorouracil, which is FEDEX, which you talked about. So it's the systemic form of that. Also, bismodegib is another medication, and it works on a certain pathway for the development of basal cell skin cancers, which most times they would have this mutation that would lead to the proliferation of these basal cell skin cancers. It can be quite helpful in certain advanced cases or metastatic disease where the basal cell has spread. Now, that's not common, but I do see this in my practice. Unfortunately, this can be a fatal disease if not treated. So it needs to be taken seriously. Most times we think about just a small defect in the skin or a little surgery, but there are those cases where it can be advanced, and everybody's different. Their immune system can behave differently. The clearance of the tumor, it can get very complicated very fast if it's grown on the wrong area of the skin too, where you want to go through and decrease morbidity or how it's going to affect people long term. So maybe it's a basal cell up by the eye and they don't want to do a huge surgery. So we try to shrink the tumor first and then proceed to surgery. Yep. So these are things that we use.
Can you just go on an oral medicine if you have a skin cancer? Is that an option, or does it depend on the skin cancer? Is that something you have a conversation with your dermatologist about?
I would definitely talk with your dermatologist. As a patient, you always have the right to choose your path of treatment, and it's our job to inform you and to educate you.
Okay.
So I have a few patients right now that are using it more in a palliative setting.
Mm,
They're at the
okay.
end of their life and they have other health issues and they don't want to undergo surgery. So this is something to consider. But once again, there are possible side effects that can
Okay.
occur with these medications.
Mhm.
The most common being hair loss, changes in taste, muscle spasms. And we could do drug holidays where we actually take people off of these medications for a period of time, and those usually resolve. And then we place them back on the medication to hopefully
Mm,
shrink the tumor. Or in some cases, around 35% or 40% can actually have complete resolution or clearance of that tumor. So, yeah,
okay. And do you ever do the orals in combination with the topical if a patient doesn't want surgery?
I do. Yeah, I will
Okay.
do combination therapy. I think
Mhm.
it's kind of a case by case situation, much like when you're doing laser. You have to put thought and you need to go through and have a good conversations with patients about what they may experience and what the risks are and what the possible benefits are. And I wish everybody responded, but sometimes they don't. And we do have to proceed to
Yeah.
other alternatives.
Okay. So basically, if you get diagnosed with skin cancer, you don't have to jump right to surgery. You can talk to your dermatologist about, so far we've covered topicals and oral medications and maybe a combination if the patient doesn't want a scar or whatever. So,
Correct. Yep.
okay.
And I think that also brings up a great point too. Besides topicals and orals, we have things such as photodynamic therapy, or for short, we call it PDT.
Yeah. Tell us about PDT.
Yeah, so in some of these more superficial cancers, we can use a medication topically to go through and activate light
Okay.
and affect the cancerous cells and
Oh,
lead to their destruction. It's really interesting. It's something that can also be used for prevention as well, but there are certain cases where a superficial skin cancer can be treated with that, in some
mhm.
cases with good effect.
And is that an in office treatment?
It is,
Okay.
yes. So we would go through and we would apply the medication that would sensitize the patient to the light, and then they're placed under a light for a certain set amount of time. And
Okay. And is there a recovery period with that?
yes, once again, so ultimately, like five-fluorouracil or these topical medications, you will see a surface reaction where you may have erosion and crusting and breakdown,
Okay.
and it can be uncomfortable, but usually it's tolerable, and there's steps that can be taken to ultimately increase tolerability.
And there's no scarring with PDT if you
Usually
choose
not.
that option. Okay.
Correct, yes, and oftentimes it can be used for things like acne and also for photorejuvenation. So there's a
Mhm.
lot of ways that we use light, just like laser, to go through and help our patients in multiple facets. So it's really fascinating science.
Okay. And contrast that with, we talked about topicals, orals, PDT with radiation for skin cancer. Can you touch on that? Because I know there's a lot of direct to consumer advertising about gentle cure and other radiation.
Yeah. So radiation uses another portion of the spectrum of light
Okay.
and the radiation spectrum. And we use these therapies to treat certain skin cancers like squamous cell or basal cell skin cancers, and they can be used pretty much all over the body. Fairly good cure rates depending on the literature that you read.
Hmm.
It's not for everybody. And if somebody doesn't want to be a surgical candidate and they want an alternative to surgery itself, it can be a good option as long as they know the risk and benefits there. Things that can occur with the use of radiation: you can have hair loss, you can
Hmm.
have discoloration of the skin, scar does happen. In certain cases, say the nose where we have cartilage, it can affect that tissue.
Hmm.
The one thing that I sometimes worry about is the possibility that with the treatment of the skin can change the way that it heals. And if you do have to proceed to surgery, if it doesn't fully treat the tumor,
Yeah.
it can make it much more difficult in terms of treatment, in terms of a surgical option, just because the tissue may not heal appropriately. And there's different forms of radiation. There's superficial radiation therapy, which is more commonly used by dermatologists. It's been used all the way back
Yeah.
several decades. So we do have experience with that.
Okay.
But in addition, there's things like a linear accelerator or other forms of radiation delivery that can get deeper into the skin. And sometimes that's what we require.
Okay.
And sometimes we use radiation after we remove a high risk tumor to
Mhm.
decrease the risk for recurrence, meaning that it comes back, or for metastasis spread to lymph nodes or other body areas. And that can be what we call adjuvant treatment to go through and increase our possibility of complete and total cure.
So if you're worried about a recurrence, sometimes you'll add, even if you do surgery on it, you'll add some radiation.
Correct. Yes. If we had a high risk squamous cell carcinoma, for example,
Okay.
maybe it tracks along a nerve,
Hmm.
maybe it's deep, maybe it has certain features under the microscope.
Hmm.
That might be something where we talk with the patient and we ultimately say, it may be my recommendation that you consider adding this to the surgery itself. So they would
Okay.
undergo the surgery. And then subsequently, after they had some time to heal, they would be treated by a
Mhm.
radiation oncologist with radiation.
Okay.
Yeah.
Okay. Well, that brings us to our next treatment, excision and Mohs.
Yeah.
So tell the viewers or listeners, what is an excision? What is Mohs for skin cancer?
So excision is the use of a scalpel or other sharp instrument to remove tissue. We have certain statistical analysis that's been done to where we can determine a margin or how much normal appearing tissue around where the biopsy site has occurred to give us a certain cure rate. So it's never 100% anything in medicine. And for example, if I was to treat a basal cell skin cancer, and there are different forms, it might be that I use a 4 millimeter margin, which doesn't sound like a lot, but ultimately that can be a 95% cure rate and lower risk of basal cell skin cancers. Whereas if I had more aggressive, I might take a larger area.
Okay.
And once again, subsequently, if you had squamous cell carcinoma, you would use a certain margin or safety area that you would go through, and that might give you a 95% chance to go through and clear that tumor. But whenever we do pathology, and this is really where the difference is between Mohs surgery and excision, when we do regular excision, we cut it like a loaf of bread vertically, and we only get to see the front side of the piece of the side of the bread and the back side of the piece of bread. But there's all this area in between where it's less than 2% of total margin, or the bottoms and the sides that we actually get to see under the microscope when it's cut that way. So there's a lot of unaccounted for tissue, and you can have little tendrils or little areas of skip lesion where you actually have cancer outside. So that's where the cure rate isn't as high as Mohs, because your Mohs surgeon would go through and they would almost take it like a Reese's peanut butter cup, and they would fold down the sides of the outer covering, and they would put it all in one plane, and they actually section it horizontally where you get a disc of tissue, and you get to see the entire bottom, and you get to see the entire side. So you get 100% margin assessment. So you can say, I know that I have looked at every area where this could have protruded through there. And that's about a 99% cure rate because of that. So your surgeon acts not only as your surgeon, but also as your pathologist, and they correlate that. And ultimately, when they look at that tissue, if there is an area of skin cancer, they can go back and they map it out to where they can go through and take a portion of tissue only in that area. And they continue to repeat that process until they have margin control and they've cleared that tumor.
So the difference between an excision and Mohs, they're both surgery. They're both going to leave a scar. They're both going to take out the cancer with a very high cure rate. The reason why Mohs has a little bit higher cure rate is because you're looking at 100% of the margin and not just 2% with an excision.
Correct. It's how we look under the microscope and how we correlate that clinically with what we're going to do surgically. And in some cases, it allows us to take smaller margins, which is a nice option, especially in high-risk areas.
Like the face?
Exactly.
Okay.
Yep, exactly. If we had something up on the nose, we don't want to take a bunch of tissue there if we don't have to. But the real goal of Mohs surgery is cure.
Okay.
And that's where it comes down to. So it may be that you may have just as large of an excision or area that we've taken out with an instrument, but your rate of cure is higher.
Okay. Okay.
Yeah.
Any other therapies that we should think about if, we have skin cancer or a loved one has skin cancer?
Yeah. So more recently, there's been advances in how do we use the immune system to fight all sorts of cancer. And these are called immune checkpoint inhibitors. And they actually kind of, if you want to make it easy to understand, we have a break on our immune cells. And if those are overactive, that's where autoimmune disease like lupus and other things likely come from. But we actually take the brakes off the immune system to attack the tumor cells. So we allow our body to do what it's meant to do, and it's not without risk. There are definitely side effects because, once again, if you take the brakes off, you can have almost autoimmune type reactions, and that can be significant. But in advanced cancers or locally advanced cancers that are not surgical options, or they prefer not to undergo that route, the use of immune checkpoint inhibitors have been used to go through and treat sometimes inoperable tumors and sometimes cure. So it's been a game changer. I've got to see some really lovely cases where people had advanced disease that really may not have had a chance before these were available, and they had remission. So it was, it's wonderful to see those types of cases when they do occur. I'm very excited for the future of skin cancer treatment and all the modalities that we have. I think overall, really excited about things like CAR T therapy, where we can train our own immune system cells, where they take them out. That's something that's pretty advanced and quite neat. We also do things like TVEC, which is where we go through and we use the herpes virus to actually go through and we take out the virus itself, the DNA from that, and then we use that growth to go through what's called an oncolytic virus, and it actually kind of ruptures the cancer cells, and that can be as well. But those are very specialized therapies. They're only available in certain areas. But I think the future is bright in some of those cases for non-surgical options that we're going to have.
And lasers, obviously.
Yes, I'm very excited for what you were telling me, and I hope that you could speak more to that. But I'm very excited about the non-surgical options that we may have to treat our patients, because not everybody is a surgical candidate.
Yeah.
I deal with a lot of frail and elderly patients, people that are in long-term care facilities, and it's not an option. Sometimes they do have locally advanced disease and they just don't want to have surgery, but they're still having quality of life issues related to ulceration or pain or bleeding, disfigurement. It's a significant thing. If you live to the age of 70 in the United States, you have a 1 in 5 chance of developing skin cancer. So strongly encourage you to stay out of the sun between 10 a.m. and 2 p.m. at the highest rates. Look at your UV index on the weather apps if you have that. That can be very helpful. Sunscreen, in my opinion, over UV index of 3. If you're anywhere above that, definitely sunscreen. And if it's 9 or above, then you want to go through and probably just stay out of the sun in total. Sun protective clothing, protective hats. Please get screened for skin cancers. If you have anything changing, symptomatic, meaning it hurts, it just bleeds, is doing anything funny, or you have a concern, at least check with your primary. I think that's a great place to start into triage. So catching things early can make a huge difference in terms of what needs to be done in your management and also your overall well-being. Yeah. So
let's talk a little bit about kind of my field, which is lasers for skin cancer, because I think, what Dr. Mastin just said in terms of the oral medicines that we have and the infusions, the immunotherapy, and the prevention side, which we're about to do another show on preventing skin cancer. So watch that if you want to learn more about how to prevent skin cancer. But in terms of if you already have skin cancer, your loved one has skin cancer, there's a lot of options that aren't surgery. And I think, in terms of when you pair the topicals, the orals, the immunotherapy, and some lasers, we're all seeing this paradigm shift happen in the market, and I think dermatologists individually, we treat different populations. Dr. Mastin is in a more rural setting, so you're seeing a lot of elderly frail. I'm in a more urban setting, so I'm seeing a lot more people that are scar conscious, let's say that, they don't want to have surgery on their face. So they're interested in other options such as laser, topicals, orals. And I think we're going to see more and more of the population kind of move to these as we get more data on them. There's more trials ongoing. And as patients learn more about the other treatments other than excision and Mohs to treat skin cancer.
I couldn't agree more.
Yeah. So I'm excited. I mean, just like you're excited for the immunotherapies and obviously learning about lasers, hopefully integrating that into your practice to treat skin cancer very soon here. I am obviously a laser specialist, so I see a lot of people that we treat for skin cancer. And I'm just really excited for the next kind of 2 to 5 years as these things get more and more attention with consumers and with patients. And, we get more trials showing that the immunotherapy, the topicals, the orals, the lasers, they all really do work for patients to treat skin cancer if you have one, and obviously prevent skin cancer.
Absolutely. Yeah. I mean, even just some of the literature on prevention of skin cancer with lasers, I think that's huge. An ounce of prevention is worth a pound of cure. And I think that's huge. I think that the data is very promising for that even. So I would strongly encourage you to consider the use of laser to decrease your risk for skin cancer in the first place. I really do wonder what will happen as this becomes more integrated into overall treatments, especially in sunny areas. But I would strongly encourage you to see somebody like Dr. Kesty, who's well versed in lasers and can provide you with the best recommendations and most up-to-date data.
Yeah. Do you think your kids are going to get skin cancer ever?
Oh, they're covered head to toe. Sunscreen and special swimsuits and hats. They're definitely a dermatology kid.
Yeah. See, my kid is like the kid at the pool that sometimes wears a sun shirt, but I'm not actually that strict with him because I'm like, well, we have lasers. Like, is my kid who's obviously blonde hair, blue eyes at, old school high risk for skin cancer, is he ever going to get skin cancer? I really don't know. I mean, probably the small portion of skin cancers that are not sun related, that are more genetic, but I'm not sure if my kids are ever going to get skin cancer because we have the laser technology. If kids start getting a laser every year at 18, will they ever get skin cancer regardless of sun exposure? I guess we'll see.
Agreed. Yeah.
I don't think so, but I guess we'll see. So
I think you're spot on. And I mean, even
mhm,
just the photorejuvenative properties where you can lengthen telomeres, like I think you've talked about in
yeah,
your podcast. I think it's very interesting to see some of those things and how this will be integrated to overall well being.
yeah. So
Yeah.
well, thank you so much, Dr. Mastin. We really appreciate all of your expertise on skin cancer treatment. So be sure to send this to someone if you know someone that has been diagnosed with skin cancer and they're looking for alternative options. Dr. Mastin is a great resource. And tell us about where patients can find you if they want to come see you as a patient. Tell us about your clinic. What's the name of it?
Yeah, thank you so much. So I actually work in a hospital setting. I'm at Citizens Memorial Hospital in Bolivar, Missouri. A few
Okay.
blocks away from there, I have my laser and aesthetics practice, and that's MD Lux in Bolivar, Missouri.
Okay.
I also have a practice in Lee Summit, Missouri, which is a northern portion of Kansas City, and that's Pioneer Dermatology. It's a one-stop shop for all sorts of treatments. So we'd love to see you. Thank you so much.
Okay. Yeah. Thank you so much. And thanks for
Yeah,
listening.
thank you all.